Good afternoon, everyone. Thank you for coming and joining this session here. I want to introduce myself quite briefly. I'm Tom Minier. I'm with the USAID's Office of HIV/AIDS. I'm our adult clinical treatment lead, adult clinical branch chief, I think is the title, but work on the clinical cascade. Really excited to have you here with this for this session. I am joined by my co-moderator, Jackie Calnan, who I first met, I think, 12 years ago. We're getting old. And she has been schooling me in the principles of quality improvement and good treatment ever since. So I have learned a ton from her, and I'm glad to have her with me. We also have 3 really interesting presentations. And while the theme, I think, is quality improvement, we kind of pigeonholed one that was a little bit more around counseling and mental health, around ensuring we have full quality services for patients, because I think it was such an interesting one. So I'm really excited to have our 3 presenters. I'm going to introduce them next. Apologies, I get my bios up. So first we're going to hear from Dr. Anna Lawino from Tasso, Uganda. She's the project director for our USAID LPHS and Coli and Acholi activity. She's a certified physician and public health specialist, passionate about health systems, policy, and advocacy, and has even been a Mandela Washington Fellow. So she'll be presenting first, and I'm going to turn it over to Ivan Chibanda with Right to Care in Zambia. He's a senior technical advisor. He's a pharmacist, I believe, right? He's got multiple pharmacy degrees. I'm not going to read them all out, but he clearly knows what he's doing when it comes to medications. With a wide experience both in the private sector, academia, and the public sector. Member of the TWG on policy and regulations, supply chain, and the DSD task force. And he's going to, Anna's going to talk a little bit about some of the QI that they've done to better tailor services to patients and reduce interruptions in treatment. Ivan's going to talk a little bit about successes they've had in scaling up pediatric dolutegravir in Zambia. And then we're going to turn it over online to Dr. Carrie Cox, who's with Baylor in Malawi. She's an internal medicine and pediatric physician. That's called sort of a super user there. She develops tools and programming to provide high-quality clinical care, mentorship, and system strengthening in HIV care and prevention with the Baylor Foundation in Malawi. And she'll be presenting a very interesting abstract on the use of phone-based counseling as something that we can integrate into our programs in PEPFAR. So with that scene setter right there, I'm going to turn it over to our first presenter. We're going to have time for questions at the end, so please feel free to write anything down. And Anna, it's over to you.
Thank you very much, Tom, for the introduction. Good afternoon, everybody, and good morning, everyone online. My presentation is going to focus, as mentioned, on the activity that we did implement to accelerate community service delivery models in Uganda to be able to improve or reduce the interruption in treatment among persons living with HIV, specifically in the Acholi sub-region in Uganda. So I would like to, first of all, acknowledge the co-authors of this abstract that work with me at the AIDS Support Organization. Just to give a brief background, the AIDS Support Organization is a 35-year-old organization that started off by offering support and counseling to persons living with HIV at the time when we didn't have antiretroviral therapy, and later on evolved to be able to provide direct service delivery to persons living with HIV. And currently, we have an activity that is providing direct service delivery for HIV and TB in 2 regions in Uganda. One of them is the Acholi sub-region that I will be talking about. So diving into the abstract that I will be sharing, the Ministry of Health in Uganda, in its guidelines, recommends that we implement differentiated service delivery models of care to be able to tailor the services to the needs and the preferences of the clients so that we have improved treatment outcomes and also optimize the clinic health system efficiency. So with that, we have 6 different models of care that are recommended under the DSDM model in Uganda, and 3 of them are facility-based, however, 3 are community-based. And one of the key core principles, according to the guidelines that we focus on, is really looking at the aspect of client-centered care, where we have to acknowledge that each of the clients that we serve have barriers or challenges that they face, and we need to tailor the services to meet their needs. And then two, the aspect of improved health system efficiency. With the various demands that are coming on board because of the need of the clients that are having HIV, we need to be able to have the transition or the move of clients who are stable into models that are less intense, so that we leave the health system for clients who are unstable to receive the support. So in the Acholi sub-region that I mentioned that we support as the AIDS support organization, we have about 70 health facilities that provide ART, and as of December 2021, we did have close to 46,000 clients on ART. And also just to mention that this particular region that I'm speaking about had about 20 years of civil war, so the health system is recovering. So when we did analyze our performance, we noted that we'd had a very high rate of clients interrupting treatment, to about 2,500 clients that were interrupting treatment as end of that period of October to December 2021. And also key to note is that the viral load suppression rate was 91%, but specifically for the children, we did have only 73% of the children having viral load suppression. So with this performance, we did embark on doing a root cause analysis to be able to determine really what are the barriers that are contributing to interruption in treatment. So with this RCA, we targeted clients that had missed appointment in this period, and specifically we looked at facilities that were contributing, that contributed 80% of the interruption of treatment. And to do this, we were able to have a tool, an RCA tool, that we rolled out and interviewed clients that were tracked in this category that had missed appointments, both at the facility and also in the community, to be able to determine the main reason for them missing the appointment. So with that, the tallies, we did use the Pareto chart to be able to analyze the results. So just to speak about the results, I think you can be able to see on the extreme left hand the Pareto chart, and the core findings of the RCA were that of the 600 clients that we did interview that were eligible for this RCA, we did observe that majority were in the age group of 30 to 39. And also interestingly, we did see that 90% of these clients were in the facility-based models, of which the fast-track drug refill was the most, having the most number of clients missing appointment. And also to note is that majority of the clients had been on treatment for at least 6 months, meaning they were stable clients and not newly enrolled clients on treatment. But speaking to the barriers that we observed, we noted that the issue of distance was quite key, and also the issue of missing the appointments or forgetting the appointments rather, and sickness. And then key to note was the issue of distance. So armed with this, we did set out an improvement aim as an activity to address the issue of attrition in the region by optimizing the client-centered care. And in this, we just wanted to be able to scale up or accelerate the enrollment of stable clients into the community models of care. And to do this, we started the use of a tool that is called the DSD Client Preference Tool. This tool helps us to identify the preferred model of care, or the preferred DSDM model that a client would want to be put on. And just to also mention that this tool, we did have support from our above site partner that provides technical assistance support to us, the local partner, in quality improvement that is supported by URC. And that's the Rights North Acholi activity. So to roll out the tool, we did have community engagement, facility engagement, and also engagement at the district level with the different stakeholders in those administrative units to be able to, first of all, disseminate the findings of the RCA, but also to be able to have the buy-in for the tool that we are going to roll out. And specifically to roll out the tool, we did pilot in 10 sites initially, and these sites were across the different levels of care where we had hospitals, level 4, and then health center 3s. And then with the tool, the health providers were able to interview the clients based on the different models that were selected for the interview, and also according to the age bands that we did have. So just to speak about the results of the pilot, and then later on what we use the results for, to highlight key is that we did observe that only 61% of the clients interviewed were actually in their preferred models of care, which meant that despite us thinking that the DSDM model is tailored to address the needs of the client, we will be surprised that there are some clients in the models that they do not actually prefer. So it's quite important that we continuously assess for the preferred model of care. And then also to note that we did realize that the preferred model of care was actually the fast track. Majority preferred the fast track drug refill, and this was followed by the client-led ART delivery. The least favored model, or the least preferred model, was the facility-based group approach. And then when we also tried to understand, based on this tool, how the missing of appointments was aligning with the mode of care, we noted that majority, close to 70% of those that had missed the appointments were actually in the facility-based models of care, which was the facility-based individual management and also the fast-track drug refill. And then tying it up with the outcome of the viral load suppression, we did see that there was good viral load suppression among those patients that were in the community-based models. However, those that were in the facility did have very suboptimal viral load suppression, as we see specifically with the facility-based individual management. Only about 53% actually were virally suppressed. So with this, we were able to roll out the client preference tool to all the 70 facilities that we support in the region to be able to quickly enroll the clients that preferred the community or preferred other models at the facility into their models. So this slide just speaks to the outcome of that activity, where with the acceleration of the enrollment of clients into community models, we did see marked improvement, first of all, in the overall enrollment of clients into the preferred DSDM models, because according to the Ministry of Health guidelines in Uganda, we expect at least 80% of their stable clients to be either in the community or on the fast track. So currently we have about 65% of our clients on those models. But speaking specifically to the community, we did have marked improvement, as we can see on the left-hand side, where we had between Q2 and Q3 a marked improvement in the community drug distribution points, and then a decline in the fast track, which meant that people were moving into the community. And this also tied up with the RCA findings, where, remember, the barriers to them not being on treatment or missing appointment was as a result of distance. So by having clients move to the community and having it as their preferred model, this addressed the issue. But also just to speak about the MMD, as we all know, it's also meant to help us differentiate care. We have marked improvement in terms of patients being on drugs for more than 3 months of care. And just for the 6 months, we have close to about 38% of our clients on it. So with that, we did see the outcome indicators also improve in terms of interruption. We've seen marked reduction in the number of clients enrolled on treatment that are interrupting treatment. But specifically speaking to the viral load suppression, we noted very marked improvement, a 10-point improvement actually in terms of the viral load suppression for the children over this period of implementation. This is just a picture showing what's happening at one of the community drug distribution points. So in conclusion, we realized that with the implementation of the DSDM model, there is need for us to be able to use simple tools like the RCA to be able to determine the structural and client-level barriers that often affect treatment outcomes. However, when we also apply the DSD client preference tool, we are able to really integrate that individualized client-centered care that we all need when we are implementing the DSD. And with that, we can be able to see marked improvement in terms of treatment outcomes, as we did observe in this study. So I just want to appreciate the USAID team in Uganda, the Ministry of Health in Uganda, the districts that we support and the health facilities, not forgetting the AIDS support organization staff, and then the URC team that did help us with the client preference tool development. Thank you.
Thanks, Anna. I can't get this mic on. I'm going to invite Ivan to come up. Really interesting stuff here. The fact that 40% weren't on their differentiated service delivery model they preferred, and that distance was such a driver. So I think there's more to talk about when we get to the Q&A. Another thing I really love is seeing all of our recipients of care on dolutegravir. So with that, Ivan, over to you.
Thank you, Tom. So my presentation is looking at treatment optimization. Basically, it's a treatment optimization in children. I think, speaking from my experience in Zambia, I think optimization of treatment in children has been a challenge across Zambia for a long time in terms of children's suppression rates when they are on treatment. And as Zambia, we have been trying to look for a best combination or best treatment for the kids, which should be able to improve our suppression rates. I think in some areas, suppression rates are as low as 73, but we're on the average of about 88% in terms of children's suppression when they are on treatment. So the introduction of DTG-10 was a very interesting change game for us, and we wanted to roll it out based on the research which was there, showing that DTG has got better treatment outcomes. I should mention that the optimization had a journey in Zambia. First, we had to move children from MVP-based regiment. We then moved to LPV-based regiments, and finally, we had to do DTG-10. So basically, this activity started last year, and for the areas where we support as USAID Action HIV in Zambia, we have got 3 provinces where we operate from, and these are rural provinces in the northern part of Zambia. This is Luapula, Muchinga, and Northern Province. We started transitioning these children over a period of time, but our main transition drive started in March, and then within that period, we managed to move so many children to the new treatment regimen. The government actually did produce a memo to give us that instruction to ensure that all children are transitioned, and this was done in February. And from February, we started preparing our teams to ensure that they adhere to the new treatment guideline which the ministry had given. So before, I think we were using LPV as our main, together with ABC3TC as our main backbone for treatment. And then DTG came on board, which was DTG-10. I should mention that we were giving DTG to older children who have 30 kgs and above, but we had a gap between children of 3 kg to 20 kg. So I think, as you can see on the screen, those are the treatment guidelines and the instruction which came through the ministry. So I'll talk of best practices for us to be able to achieve what we achieved during the period. So first, we had to make sure that in the period before we started the transition, that was between February and March, we had to engage with all our facilities as we support 275 facilities in that region. And we had to make sure that we did capacity building of all the staff, both for Action HIV and also MOH staff in best treatment guidelines and what the government had put in. So I think I should mention that it was still in the COVID era, so we couldn't have large meetings as per se. So most of our engagement was virtual meetings with staff in all the facilities. And those staff in the facilities where we could not get through visual, because we know that in some rural areas we have network connectivity issues. So we had to mobilize loving teams, which could go to facility and orient staff on site. So we used two methods. So we used virtual meetings and also the site mentorship of staff. The next exercise which followed after that was for us to do file audits of all pediatrics we had on our TS car and make sure that those who qualify for DTG-10 were identified, and so that we are able to know how many children each facility had, and then we are able to know where do they stay, do they have parents, contact their caregivers. So we had to do that, and once we had that data, we were able to start tracking these clients. Those who had communication devices were able to call them and bring them to the facility for treatment. But I should also mention that we also had community sensitization efforts which were done through our lay counselors on the ground, and we had IC materials which were produced by the ministry, which specified the information about DTG-10, just to make sure that we have got community buy-in. So that was another strategy. We moved further to provide treatment aids or job aids to our facility staff. This included dosing charts, all the information they needed to make sure that they are able to make decisions. And we ensured that all facilities had weighing scales, because we know that weight was key for us to determine and to transition these kids. The other important function which happened in the preparation process was also to ensure that we had quantification. So after we got audit reports from all the facilities, we had to quantify commodities which were required for all the kids in those facilities to be transitioned. And as Action HIV, we worked closely with the Ministry of Health and our Medicine Supply Agency to ensure that all facilities received the commodities which they required to ensure that they transition all the kids. We also make sure that we did stock management mentorship to all facility staff, just to give them a heads up that you have got this commodity now. For you to be able to transition effectively, this is how you are going to do things. If you come out of stock, this is the process which you are supposed to follow in case you have going to lose stocks or you need more stocks. So we had to do those stock management processes at facility level as well. So basically, this was our performance in terms of after putting those interventions. So you can see that we started from April to July. We managed to move about 1,476 clients to DTG-10, and this was done in a period of 4 months. I should mention that by this time we have already done 100%. It's all 100%. Everyone who is eligible is on treatment. We made sure that we also have enough commodities in these facilities for refills, because most of them, they were receiving minimum of 3 months of supply. So we made sure that there's enough commodity for refills as the children were being transitioned. So in conclusion, I should mention that this activity was done for us to be able to manage these processes well. I think preparation is key. And as a conclusion, is that if you work closely as a team and prepare yourselves and make sure that all stakeholders are involved, it's possible for us to achieve much more. And I think this was an effort which was done collectively by Action HIV, MOH, and it was very pleasing to see this happening. The other issue which I want to bring about is that going forward, I think the teams now, they are working at ensuring that we want to track the virology issues around these kids. Remember in my opening remarks, I mentioned earlier that we have had this challenge of suppression in children. So what we are doing now is to ensure that from the baseline viral loads which these children had, we are now going to be monitoring them, and in 1 year's time, we want to see what impact DTG10 will have around viral load suppression. And then the other issues we are looking at is to ensure that refills are done properly and commodity supplies are there all the time to avoid interruption in treatment. I think I end here. Thank you.
Thank you so much, Ivan. Those results speak for themselves. Doubling 44 to 96% over 4 months is fantastic. So kudos to you and your team. Okay, I'm going to turn it over to Carrie. I'm not sure if you can see me, Carrie. I have this fancy clicker here that should allow me to move the slides forward. I'll need you to say next slide since you have no access to this fancy clicker, and I will do my best. So Carrie, over to you. Uh-oh, hold on. One sec,
Okay.
Carrie. Right now, don't get me wrong, you look great. We have your face on the screen, but we don't have the slides to go with them. I'm going to see if we can fix that. Here we go. Now we have both your face and the slides.
Great.
Thank you.
Okay. All right. I can't see the slides, but
There's a delay, Tom. There's a delay. Maybe tell her that.
great. Now I can see them. Great. All right, so thanks so much for this opportunity to present on behalf of our Baylor Malawi team. We're happy to share our experience expanding access to psychosocial counseling, utilizing phone-based services in Malawi. You can go to the next slide. I have nothing to disclose. The next, yes. So as you all are well aware, many people living with HIV experience psychosocial challenges, including coping with their diagnosis, living with a chronic illness, stigma and discrimination, gender-based violence, depression and anxiety, and challenges with disclosure, to name just a few. All of these obviously affect the overall wellness, as well as can impact their engagement in care, retention, adherence, and clinical outcomes. Counseling can certainly help, but unfortunately access to counseling services is limited, and there are multiple reasons for this. There's limited awareness about mental illness and psychological distress, and then stigma that surrounds mental illness often affects people's health-seeking behavior as well as healthcare delivery. And not only that, but if you want services, there are few trained providers. Exactly, the next slide. In Malawi, psychosocial counselors provide expert counseling to clients. So Baylor Malawi started supporting psychosocial counselors in 2017 with 3 facility-based counselors. By 2020, we supported 10 psychosocial counselors at high-volume facilities in Baylor-supported districts. So services were primarily for people attending these facilities where the counselors were based. And if you had clients from other facilities, they were certainly referred, but oftentimes clients didn't complete these referrals, citing transport costs and time traveling as barriers to reaching care. Sometimes psychosocial counselors would travel to the site on a client's clinic day, but those were quite few that actually happened. Go to the next slide. So with the first COVID-19 wave and movement restrictions that aim to decongest health facilities, Baylor Malawi pivoted to virtual phone-based counseling to allow continued service delivery to people living with HIV. There was an added benefit of expanding access to all 120 Baylor Malawi supported facilities with phone-based counseling. So we're reporting on this first year from June of 2020 to May of 2021 in 120 health facilities across the 7 districts that are highlighted in green. So all of these facilities are supported by our Baylor Malawi Tangate outreach program with site-based staff that include community health workers, lay counselors, and clinical mentors that are either based at the site or travel to the site on clinic days. So you can go to the next slide. So to deliver phone-based psychosocial counseling, all supported sites got mobile phones, as well as the psychosocial counselors, and the clinical teams and facility level staff were oriented using virtual meetings to this new phone-based service delivery of counseling. The priority groups for counseling were people with a HIV new diagnosis an treatment interruption, a high viral load or adherence concern, disclosure support needs, mental health concerns like depression, anxiety, suicidality, alcohol or substance abuse, survivors of gender-based violence, and anyone who self-referred or if a clinical provider referred them for psychosocial counseling. WhatsApp groups were created for referral from the facility to the psychosocial counselors. The site staff would send a message to the WhatsApp group with the facility phone number, and the psychosocial counselor would call back as they monitored the groups in order of receipt of the message and urgency of the need. And they counseled the clients using those facility phones, or if the client had their own phone and preferred, then the psychosocial would call them back on their own phone. No travel was required for the client to get counseling, and almost all counseling was done on the same day. You can go to the next slide. So over the year that we reviewed, as you can see in the pie chart, about 75% of clients were referred for adherence support, a new HIV diagnosis, or retention support after an interruption in treatment. The clients were referred primarily from the lay community health workers, which was really intentional because we wanted to utilize the waiting time that people were at the facility waiting for their clinical review. So if they were identified as someone who had a potential benefit from talking to a psychosocial counselor, they could use that wait time to talk with the counselor. An additional 5% were referred by clinical providers and 3% of people self-referred. As you can see, nearly all the clients referred were counseled, 99.4% of them. And visits were mostly less than 30 minutes, half less than 15, half 16 to 30. And there were about less than 10% that were 30 minutes. So if you go to the next slide, this one is a little bit busy. We'll walk through it. But if we look at the change in service delivery before implementation of phone-based counseling and after implementation, we can see that in the year that we're looking at, we had 30,000 counseling encounters in this year one. We use this interrupted time series analysis to compare our program data from 21 months before implementation to 12 months of implementation. And we found this dramatic and significant immediate increase in the number of counseling sessions that started just in month one. So if you look at this graph on the top left, if you go to the far left, that's the number of counseling sessions that each psychosocial counselor did per month. And there were about 62 each month up into the vertical line, which is when we started the phone-based counseling. They did one more session per month. So they were doing about 77 counseling sessions per counselor per month. And then we implemented phone-based counseling, and you can see the dramatic increase. And they started doing 216 counseling sessions per counselor per month, which was statistically significant and was maintained throughout the year. If you look at the table below and you compare the second and the third column are pre and post implementation of phone-based counseling. And in all measured variables, the number of encounters per month, per counselor, and per day increased in a statistically significant way. And both the men and women counseled increased as well. So you can go to the next slide. So these are heat maps that demonstrate the number of clients counseled from each health facility. And so the map on the left are the facilities pre-implementation of phone-based counseling. And the yellow dot is the facility, and the red dot means that a counselor is based at that facility. And you can see that all of the clients counseled came from the facilities where the counselor was from. If we look at the map on the right with the green dots, that's after phone-based counseling was started. And you can see that clients came from all 120 health facilities. And the larger the size of the dot means more clients came from those facilities. So certainly some facilities referred more than others or had larger cohorts, but every single facility, clients from that facility had access to the psychosocial counselors. Taking the last slide. So in conclusion, COVID mitigation realities really did create an opportunity for us to adjust programming to this delivery of phone-based psychosocial counseling. And we were able to rapidly and effectively roll out this service delivery that allowed many clients access to services that didn't have access prior. We think this phone-based model can really help continue this access, especially where services were previously unavailable and even where phone networks and connectivity are limited. We're still looking at the impact on medical outcomes, and we have continued to utilize phone-based counseling as we've also returned to in-person service delivery at our high-volume facilities. I think the next slide is just a thank you to the whole team. Yep, so to the clients, to our team, Ministry of Health, USAID, and everyone that worked together and continues to work together on all of our programming. And that's all. Thanks so much.
Thank you so much, Dr. Cox. For those of you that joined the treatment updates section just a little while ago, I talked about how important mental health is going to be in the coming years as one of the areas that we plan to expand. So I think if we have the ability to leverage phone-based tools, that's what makes this abstract so exciting. So with having heard from our three fantastic presenters, we're going to open the floor to any questions that you have, and I know Jackie's been trying to monitor the chat for any that pop up there as well. Please feel free to come to the microphones up here if you do have a question. And perhaps I can start with Anna while folks come up to the mics. Anna, I was curious, you presented a very detailed picture of the root cause analysis, what was causing clients to leave care, and the fact that you assess preference. How often do you do that? Because you can't do this every day. Is this something you do once a month, once a quarter, once a year? What's the optimal frequency, knowing that it does take some time and energy?
Thank you very much, Tom, for that question. In regards to how often we do the RCA and also the client preference, for the RCA specifically, because we were trying to identify really the barriers to the interruption in treatment, we do it every quarter. We started off doing it every quarter. However, with time, we realized that you need some time to address some of the structural challenges. So with that, we modified to do it every 6 months. That's for the RCA, to be able to see newer barriers and also allow for the time for the interventions that you put in place to address the barriers that are top when you do the RCA. So we are doing it every 6 months, which is twice a year. And then in terms of the client preference, because we realize also we have a number of clients on 2 multi-month drug dispensing, which means they interface with the health system in a longer period of time. So what happens, because now we've integrated it into the care to administer to clients when they interface with us, meaning that if a client is on a 6 months refill, we will administer the client preference tool twice a year, just to be able to ascertain this time, this is your preferred model, are you on it, and if you're not, we will enroll you in the model that you prefer until the next 6 months when you interface with the facility. So it has become part and parcel of the routine care, just to check, because sometimes even with a client accepting to go on a client-led approach, they might not allow with the dynamics there that is in the client-led and want to return to another model. So it's routinely administered for the client preference. Thank you.
Great, thank you. And I see a question up here.
Yes, thank you so much, moderator, and thank you so much, the presenters. Juko Richard is my name. I come from Uganda. My questions go to Ivan. Yes, thank you so much for that very wonderful presentation on optimization to pediatric DTG. However, I just needed some clarification. Within the space of 4 months, we see that the results have been quite tremendous. And we know that one of the barriers to optimization has been the management of the non-suppressed clients. So I just wanted to get some more light on how your team has managed to improve suppression and then resultantly to optimization to pediatric DTG. The number 2 is that in Uganda, one of the reasons or one of the barriers that we have seen has been distance to the health facilities to be in position to receive all services, including pediatric DTG optimization. So I just wanted to know whether with your team you managed to do any community interventions, because I still think that we might be having some, children who are faced by access challenges, and so they may not quickly access the pediatric DTG. Thank you very much.
Thank you for those questions. So I'll start with the access to DTG-10. So as I mentioned earlier, that, our process, we ensure that at first we did facility audits of all the children. And in Zambia, we have been doing pediatric SAGE from last year. So you find that we have managed to reach a lot of children, and we are monitoring the children in both retention and suppression over a period of time. So when we are doing the DTG-10 rollout, we needed to make sure that we reach all the children we have on our text car in the region where we serve. And because we had the data, we had the information, we had all the patient file already done, it was easy for us to reach out to most of those children. As I mentioned earlier, that we have actually reached 100% for those who needed to be transitioned. Right now, we are only concentrating on new on treatment. Those are the ones we are putting on DTG-10. So I think that one we did quite well. I know there could be children maybe who could have missed, but I think we're also running a Know Your Child status campaign in Zambia. And immediately we identify a child, we'll make sure that they are linked to treatment, and those who are eligible for DTG-10, we give them. And the other children, obviously, we give them TOD or TAFET based on their weight band. In terms of viral suppression, I mentioned that those are among our next steps. We have the baseline viral loads for the children who have transitioned. And if you look at this transition happened up to July. So we have given ourselves a 12-month period in which to make sure that when they come for the next viral load, we want to monitor all the children who have transitioned in this period, and make sure that we monitor their viral loads and check what their viral loads will be. What we expect, based on the information we have, we expect to improve our viral load suppression. As I mentioned, that our suppression in children was averaging between 73 to 88%, depending on the region. But in our region, we're around 88% suppression in children. So we want to see a change in terms of how that will be. I'm sure if we meet next time, we should bring another abstract talking about how we manage suppression. Thank you.
Thank you, Ivan. Dr. Ben?
Thank you very much. Thank you very much to the presenters. Very exciting abstracts and presentations. My interest is to Bella, and in fact to build upon your question about mental health. I noticed that in terms of counseling, the focus was more on the basically treatment-related activities. In the introduction, you referred to COVID, and COVID was a period of stress. In fact, in our program in Zambia, one of the major challenges was, apart from the clients, our staff themselves having been affected, required psychosocial counseling. Similarly, the clients, once they came down with COVID, the major or additional aspect was also psychosocial counseling on COVID. And this basically related to mental health. Did you encounter that in this program? Thank you.
Sure, can I take that?
Yes, I was hoping you caught it all, yes.
I did, yeah. No, thank you very much. We certainly also have definitely a period of stress with COVID. We have actually a psychosocial counselor now with Baylor that is dedicated to providing psychosocial counseling for healthcare workers only, especially to try to mitigate some of the stress related to COVID, but also just the workforce stresses with COVID. And we do have that one dedicated psychosocial counselor. We certainly saw people for all reasons, but COVID was a vast minority of the reason that people were referred, which is what we were collecting here. When the psychosocial counselors did talk to people, COVID did sometimes come up, but we weren't collecting like the issues that the psychosocial counselor addressed in this first year. We were just seeing the reason that the clinical staff, our lay staff, were identifying as why people needed to see the counselors. And COVID was mentioned, but it wasn't as common as the other reasons, but it definitely happened. Thanks.
Thank you. And I actually am remiss to say that we are out of time, which makes me sad because I have many questions for the presenters just myself. But with this, I want to give a round of thanks again to our presenters, the three of them, for this session. I know that Dr. Anna and Ivan are trapped up here with me, so if you do have additional questions for them, you can come up here. And I don't know, Dr. Cox, from your end, if there are additional questions, if you're willing to field them by email, but we can certainly pass those along. So thanks again to everyone, and I hope you enjoy the rest of the day.
Thank you.